Hey everyone, coming back to you with the answers to this week's HQ challenge number 13. We're talking about hypoxias again this week. So we have a patient with a new onset of atrial fibrillation, the rate's 172, that presents to the ED intensely cyanotic with a BP of 60/30. Okay, so we can agree this person is probably going to have a degree of hypoxia. So what type of hypoxia is present? And we've got all four here: hypoxemic, anemic, circulatory, and histotoxic. So anytime we have a shocky situation, profoundly low blood pressure, that can be caused sometimes by a cardiac issue, and with AFib, there's probably not enough of a squeeze of the atria to send blood to the ventricles for the ventricles to pump out adequate cardiac output. This has everything to do with the heart, with cardiac output, and with blood pressure. So that type of hypoxia is circulatory hypoxia. So if you want a good example of the four types of hypoxia, I've got a great YouTube video that differentiates between hypoxemia and hypoxia. Check that out, but this represents circulatory hypoxia. So let's go ahead and spin this into a second-year student question. That patient that we just had, that had atrial fibrillation, that had the heart rate of 172 and had that low blood pressure, 60/30, we got to do something, and we got to do something fast for that patient. So which of the following would be the immediate treatment oxygen? Well, obviously we're going to put oxygen on them, okay? But with that, we are going to have to perform synchronized cardioversion, all right? So we cannot do defibrillation. Defibrillation is for VFib and pulseless VTach. That's not what we've got going on. Synchronized cardioversion is done for arrhythmias with fast rates that have a palpable pulse, that the person's experiencing symptoms. And so that described our patient with AFib, a rate of 172 with a blood pressure of 60/30. So we definitely need to cardiovert that patient. And what the difference between cardioversion and defibrillation is the defibrillation, when we hit that shock button, it lets the electricity go immediately to the patient's chest. When we synchronize and we cardiovert, that electricity is synchronized to the R wave of the QRS complex. So when we hit shock, the machine waits to release that electricity, so it releases it right on top of the R wave and hopefully resets the heart. Transcutaneous pacing is typically for heart blocks, second and third AV blocks, and then beta blockers. While that might be indicated for atrial fibrillation, because it was an emergency situation, we're not going to take time to put an IV in to deliver a beta blocker or to give it orally. We don't have enough time to mess with that. So the correct answer here would be oxygen and cardioversion. So hope that helps. See you soon.